Hello, good morning everyone. I'm Dr. Deepti Aggarwal, Assistant Professor in the Department of ENT, Santosh Medical College, Ghaziabad. Today I will present a small talk on this epistaxis. So, a very common and interesting topic it is. Epistaxis refers to nosebleed or hemorrhage from the nose. It is defined as hemorrhage which is caused by a rupture of tiny distended vessels in the mucous membrane of any area of the nose. It is fairly common and is seen in all age groups. Its most common origin is from the anterior part of the nasal cavity. The site, as I said, it is mostly from the anterior part of septum, which is because there three major blood vessels are entering the nasal cavity. The anterior ethmoidal artery from the roof coming down into the forward part of the nasal septum, the sphenopalatine artery which comes from the posterior superior region, and then superior labial branch, septal branch of the superior labial artery which enters from inferiorly, which is a branch of internal maxillary branches. So, all these small branches come together to create a vascular area that is called Little's area or the Kieselbach's plexus. This is the most common site of origin of epistaxis. So, likewise, there can be other areas of epistaxis also. So, broadly, epistaxis is classified into two kinds, anterior or posterior. Why this classification? Because this matters according to how we deal with it, what kind of presentation there is and what will be the management. So, anterior epistaxis is most common. It originates from our Little's area, then it occurs most commonly in children or young adults. It is mostly traumatic, caused by the fingernail trauma, caused by the drying effects of cold dry vents or hot dry vents, which lead to crusting in the anterior part of nasal septum, and then when the child will pick the nose, then after removal of crust this bleed will come. So it is usually mild and can be controlled by local pressure, by which will be discussed further, or if it is not controlled by pressure methods, then we have to pack the nose anteriorly. Likewise, posterior epistaxis, it is much less common than the anterior epistaxis. It does occur in adults, mostly after 40 years of age, who are hypertensive or have arteriosclerosis. It occurs from the posterior superior part of nasal septum. The bleeding is arterial, and because either it is idiopathic or because of hypertension, so the bleeding is very severe, which may require hospitalization and a posterior nasal packing. The causes may be divided into local, systemic and then idiopathic. The local causes mostly are drying leading to crust formation. Bleeding occurs with removal of crust by nose picking, rubbing, blowing, anything, any trauma, direct blow to the nose, infections, viral, bacterial or foreign bodies, a rhinolith, which is a neglected foreign body. So any child which comes with epistaxis, you have to be careful and look for meticulous inspection of the nasal cavity is required to rule out any foreign body, whether the patient gives history or not. Then look for any atmospheric changes like high altitude, sudden decompression, or structural changes like deviated nasal septum, sharp spur, which might cause this epistaxis. Then systemic causes will be hypertension, arteriosclerosis, renal disease, bleeding disorders, liver disease like hepatic cirrhosis, anything which is interfering with the coagulation of blood, because any injury to the blood vessel wall, it should heal on its own in 5 to 10 minutes. If it is not happening, then that means ki there is some defect in the coagulation pathway, and so systemic causes have to be ruled out always. Then any disorder of blood or the blood vessels like aplastic anemia, leukemia, thrombocytopenia, hemophilia, scurvy, K deficiency have to be looked for and ruled out always. How do we approach to management? As with any disease, a meticulous history is the key. A meticulous history is the key to diagnosis and management. History should include the amount of blood loss, the duration of blood loss, how many episodes have been there, is there any history of drug intake, any systemic disease, any medical history, any surgical history has to be inquired upon. Then history of any coagulopathy in the family, any known bleeding tendency in the patient or in the family which has not been previously diagnosed, like hemophilia or aplastic anemia, these have to be looked for and always inquired upon in history. Then examination, you have to carefully inspect the nose, both right and left nasal cavities with a nasal speculum. It should never be only unilateral examination. Even when the patient has a unilateral bleed, we should carefully inspect both the sides of nasal cavity to determine site of bleeding, and also any other significant local finding has to be ruled out. So meticulous examination of the nose and nasopharynx. Then we send lab investigations to exclude blood dyscrasias and coagulopathy. Further management will depend upon the location of the bleeding site. After we have determined the site of bleeding in the nasal cavity, initial treatment will be applying direct pressure and cold compression with ice packs. Direct pressure, it is also called Rotter's method. You have to ask the patient to pinch the nose with thumb and index finger, open mouth and sit leaning forward. Patient is asked to breathe through the mouth and sit quietly leaning forward, and any blood which trickles down the throat and comes in the mouth has to be spitted out. At the same time, cold compresses can be applied to nose, which will cause reflex vasoconstriction. This pinching has to be applied for 8 to 10 minutes for the coagulation to take place. Then if this measure is unsuccessful in the bleeding, the area if we can see the site of bleeding, then the area can be treated with a chemical cauterization like silver nitrate applicator. Other topical vasoconstrictors such as adrenaline and phenylephrine can be applied, packs can be applied on the site of bleeding for 10-15 minutes or can be left for a day, and then patient can be called back for review. But if the bleeding is occurring from the posterior regions, first of all, it is very severe. We don't know if it is left unattended, the patient might go in shock. So it is very important to ascertain the site of bleeding, and if we think it is coming from the posterior region of nose, then we have to pack the nose. Packing, there are many things, many ways of packing. The traditional method of packing uses ribbon gauze impregnated with antibiotic and emollient like liquid paraffin, and then this pack is placed inside the nose, or alternatively easier way is now modern pre-made nasal packs are available in the name of Merocel, which can be inserted. Then before inserting, a topical anesthetic spray or a decongestant agent may be used prior to inserting the gauze. Then the pack may be left there for 24 to 48 hours, and antibiotics are prescribed for this time. The pack is in situ to avoid the risk of iatrogenic sinusitis and toxic shock syndrome. So while we are using Merocel, we have to be careful that Merocel has to be inserted horizontally along the floor of nose. The movement of the direction of insertion is very important, and we have to be very careful while we are doing packing. Either whether we are packing with Merocel or we are doing it with ribbon gauze, always the pack has to go parallel to the nasal floor. So Merocel is inserted parallel to the nasal floor, and then we push 10 ml normal saline so that it impregnates and increases in size, blows up in size. Then the second method, ribbon gauze. In ribbon gauze, parallel stacks of ribbon gauze are placed inside the nose till the cavity is fully full with this ribbon gauze. Then posterior nasal packing. For posterior nasal packing, we can use ribbon gauze, Foley's catheter, or nasal balloons. So while inserting, these are the different methods of doing posterior packing. First, we insert Foley's catheter in the posterior part of nose, that is choana. This balloon in the Foley's catheter will act as a physical constrictor, and it will give pressure and the bleeding will stop. Then anteriorly, to let the Foley's catheter stay in place, again anterior nasal packing is done, or these days nasal balloons are also available, which can be put just like a Foley's catheter, and there is an anterior nasal balloon also, which both the balloons can be inflated, and then there is no requirement of this ribbon gauze packing. So these are much less traumatic in trained hands than the anterior nasal packing. Then if these less traumatic methods of packing fail, then we have to go for ligation of vessels. Ligation can be done external carotid artery ligation, maxillary artery ligation, or when it is coming from the superior part, then ethmoidal artery ligation may be required. So this ligation also can be done nasally, endoscopically, sphenopalatine artery ligation, that is called TESPAL, or also if available, then embolization of the specific artery can be done. So apart from these general measures like making the patient sit up with backrest, record any blood loss taking place through spitting, vomiting, mild sedation should be given, the vitals should be monitored, maintenance of hemodynamics, like any blood which is lost, the patient should not go into hemorrhagic shock. If he requires any blood transfusion, that should be restituted, that should be given. Then antibiotics should be given to prevent sinusitis, and intermittent oxygen may be required because in case of bilateral packs, patient becomes very anxious and the SpO2 may dip. So in the meantime, we get any investigations done, and then treatment of the underlying cause in case of general systemic diseases. Then if these are